So, as I said earlier this morning, I'm an obstetrician. Grégoire Jovian is on the place, and he's sitting just right there. And we work together to develop, as an engineer and an obstetrician, to develop a model in order to predict and detect hypoxia from cardiotocography. So cardiotocography, CTG, is widely used to monitor these features during labor, and CTG is something quite promising that we can use to improve detection of fetal hypoxia, and the main point is the timely manner. But if you look at the RCT, the randomized controlled trial that use computerized CTG, they fail to improve neonatal morbidity. There are different hypotheses for this failure. The first one is the poor accuracy of the model used in this RCT. The second one is that the computerized CTG was not really integrated in the care procedure. People don't know how to use it, don't know how to interpret it, and they didn't use it correctly. And there's a main point is that RCT is a good way to validate this kind of software. So this is our project. It's called the DeepCTG, and we have 3 work streams we work about and around and in parallel. The first one is to build a multi-center French database with our own practice, and build and validate a model to predict hypoxia or fetal well-being if hypoxia is not the right outcome. And we work also to integrate this kind of software in the labor ward. I'm a PhD student. I'm a doctor, but also a PhD student. This is my first year. And I have 2 supervisors, an obstetrician, Julien Sturneman, who specializes on AI and fetal imaging, and Erwan Le Pennec, who is a professor and data scientist in an engineer school in Paris. It's École Polytechnique. So we first had this first work on logistic regression that helped us interpret and understand how the signals works. So we compute the CTG signals into 24 features or 35 signal features. So we use the minimum value, the maximum baseline. We also try to understand how the deceleration works. So we compute the area of deceleration, the area of acceleration. We try to analyze the difference time between the depths of acceleration and the highest point of uterine contraction. So we use you use our guideline to compute this signal, and we try to use all these features to predict hypoxia, and we try different model with different features in it, and we understand that with only 4 features, and they were area of acceleration, deceleration area, minimal baseline of fetal heart rate, and the maximum baseline, we reach the same accuracy than using all the more complex features. And we had a ROCOV of 74% on a CTUHB cohort. So the second point of our research was to develop a state-of-art algorithm using deep learning model to predict fetal hypoxia during labor. We chose to have 3 different outcomes. We defined the normal outcome with the pH threshold to more than 7.20. We defined also moderate hypoxia and the severe hypoxia with the pH threshold below 7.05. We use 5 different data sets to have in this project. The open source data set, CTUHB, that many people use to validate their algorithm as it's an open source. We also use the SPAM dataset that it was 6 years ago. You did the CTG challenge, and we had the chance to have this access to this data, and the APHP dataset that I presented earlier this morning. We designed this model with the 16 last minutes before delivery, and we used to validate it with the cross-center validation way. It means that to validate, for example, on C2HB, we will train it on all the different centers we have, except the C2HB, and we did it for every center we have. So these are the data sets. I've already presented them this morning. I just added the CTUHB and the SPAM dataset on the table. We had around 30,000 cases and 560 PH before severe hypoxia, and 3,400 of moderate hypoxia, and the rest was normal cases. We have around some vaginal delivery, opera delivery, but also cesarean during labor. And we have a general quality of data which was below 20%. So this, the model was a classic CNN model, if I can say this as an obstetrician. But we just had a particularity that we pre-trained this, we had the first step, that we pre-trained our CNN by asking the model to predict not our outcome, the pH level, but they have to predict the different CTG features that we try to learn before. It means we made him understand, predict if there is an acceleration, deceleration, if there is a normal, if there is a long-term or short-term variability and other CTG signal. Then we use in an input raw data we use FHR and uterine contraction, and then we ask him in this final step to predict. To give three prediction and probability for normal pH, moderate hypoxia, and severe hypoxia. So those are the performance of our model. So this is the results of an IVC with the ROC curve with the correct session validation. And we also put on this, in this graph, the clinical practice. We define a clinical practice by intervention by obstetrician, or well, mainly obstetrician, to do a cesarean or an operative vaginal delivery for a fetal distress reason. And we noticed that as there are three different hospitals, there are different practice. In Beaujon, for example, dataset, I'm sorry, it's very small. In Beaujon dataset, for example, which is in red, we had a false positive rate in clinical practice around 15%. And compared to Robert Debré, who is in red, who had a false positive rate of 17%, but a sensitivity higher with almost 50% of sensitivity. And in all those cases, so if we see the results of the performance of our model, we see that it generalizes well from one center to another, and from one center to another one, and the accuracy is quite interesting, and it's from 70% to 80% if we compare the lowest. This was for C2HB, and the highest performance was for a SPAM dataset, which is the challenge dataset. And in all the cases, except in Robert Debré, the models perform better than human practice. So once we had these first results, I want to see what are the factors that impact the prediction of accuracy, and then how can we improve more our prediction model. So the first one is the mode of delivery. On the one hand, we have the vaginal birth with all these complex forces and mechanical forces that are applied on the head of the baby. We know that the women are pushing, then there are less oxygenation of the placenta during the pushing. And on the other hand, we have this cesarean, where the major bias in the cesarean, that decision is decided by a human, by an obstetrician, because of abnormal fetal heart. So it was natural to say that maybe there are two models that are needed, one for the vaginal delivery and the other one for the cesarean. So we did the test. We trained on cesarean only and validated on cesarean or validated on vaginal delivery. And we also do the other model, we trained on vaginal delivery and validate on cesarean and try from one point to the other one, and it doesn't improve the accuracy of the model. The second point is the clinical context. We know that all the information of hypoxia or fetal well-being is not in the CTG signal. The CTG signal, when we just think about it, is just a heartbeat. And we want to know lots of things about this heartbeat. But we thank you, Austin, for the presentation tomorrow. So you give us all the explanation of how we choose a low-risk data set. And so we try to create another group of patients that are that didn't have anything in their obstetrical context, their personal characteristic or their fetus characteristic that can explain why there is an hypoxia in the signal and we didn't see it. So we exclude all the post-term pregnancy deliveries and pregnancies. We exclude the intrauterine infection during labor. We exclude also the diabetes and the hypertension disorder, the fetal with intrauterine growth restriction, and also the fetus with macrosomia. And sorry, we exclude also people with a high level BMI. So we trained this new low-risk data set and validated on the low-risk data set, validated on the high-risk pregnancy, validated on all pregnancies. We do also the train with a high-risk pregnancy, validate on low-risk pregnancy, and it doesn't improve the accuracy of our model. And the last point is the signal quality. We try to separate and classify the different CTG on 3 categories: low, medium, and high quality. And for these points, the results are more interesting, and the highest quality we get and the highest accuracy we will have with the model. And it's interesting that in Robert Debray's cohort, which we were in all cases, when we take into account all the cases with the different segment quality, different context, the human analysis was better than the clinical practice was better than the algorithm. But in case of high quality signal, we reach the algorithm is slightly better than human practice. So, sorry. I can't find a table, but it's fine. Once we had this low-risk data set, I was wondering, okay, what can I do to go further and to understand how the algorithm didn't get it and what information did we miss? What are the other factors that could influence the CTG analysis? So I analyzed the false negative cases, which means the cases where they were fetal hypoxia, but the algorithm said that it was normal. And there are 3 different points and 3 different group that merged. The first one was the quality signal. They are like third of files where they have a low quality signal, and this is why the algorithm didn't have the data, so he just said it's fine, but it wasn't. The second one is the I will put it on the first one, is the the maternal heart rate. In some cases, it was we registered the maternal heart rate and not the fetal heart rate. So he thought it was normal, but it wasn't. And the second point were some cases there are like unexpected, for example, umbilical cord prolapse, delay between the end of the recall and the birth, and in this point we didn't have enough data to interpret the CTG. This is why he said it was normal. For example, for people that are not common with the umbilical cord prolapse, cord prolapse is when the cord is going out from the vaginal tract, but the baby is still in the uterus. This is a huge emergency in obstetric. You have to run to the OR and to the C-section. But from the moment we stop the recording and the moment the baby deliver, it could last 10-15 minutes. And during this 10-15 minutes, the CTG is getting worse. but we didn't have the information as it wasn't recorded. And this is why at the time the analysis was made, the CTG was normal, but from the moment we stopped the recording to the moment he delivered, it's getting worse, but the algorithm didn't know it. Sorry for the table. So this model showed the ability of a deep learning model to generalize from one center to another, and specifically one center that centers that have very different clinical practice. And the analysis of the false positive case gave us some direction of future research. First one, I have to improve signal quality. The signal quality could be improved thanks to better devices, to the better detection of maternal heart rate in the CTGs without having the maternal heart rate register, and maybe some imputation of imputation algorithm could help improve this quality signal. The second point is the impact of clinical context. We all agree that if I understand well the conclusion of different presentation, that we have to introduce this clinical context in our future model. And maybe I choose pH because pH is something we use every day in labor ward, but maybe pH is not the better outcome. Maybe there's other outcome to evaluate the fetal well-being. Thank you.